Hello and good afternoon. Welcome to our webinar about the Evidence for Action Making Health a Shared Value Call for Proposals. Evidence for Action, or E4A, is a signature research program of the Robert Wood Johnson Foundation, housed at the Center for Health and Community at the University of California, San Francisco. I am Erin Hagan, the Deputy Director of Evidence for Action and your moderator today. Joining me is E4A Director Nancy Adler, our Research and Policy Specialist Maylin Tan, and our Robert Wood Johnson Foundation Senior Program Officer Claire Gibbons. Today we'll briefly introduce you to Evidence for Action and give you a little bit of a sense of the action area that this Making Health a Shared Value call emanates from within the Foundation's action framework. We'll discuss why we've released this solicitation and our funding aims, and we'll review the drivers that fall within the Making Health a Shared Value action area. We'll go over grant details, selection criteria, how to apply, all the logistics. I want to be clear that the webinar is intended to serve as a supplement to the call for proposals. So if you haven't read the CSP yet, I encourage you to do so, along with the frequently asked questions section of our website. We've also set aside quite a bit of time at the end of our presentation to answer your questions. Throughout the webinar, you can chat your questions into the chat feature on the left-hand side of your screen, and we will get to those, as many of them as possible, at the end of the presentation. If you have any technical issues during the conference, someone from ReadyTalk, the platform hosting us today, is also monitoring the chat and will be able to assist you. And I want to state up front that this presentation will be archived in its entirety on our website following the presentation today. So with that, let's jump into the content. The mission of E4A is to support research that is likely to yield convincing findings regarding the population health, well-being, and equity impacts of specific policy and program interventions. We achieve this mission by awarding grants through our general rolling call for proposals and through this recently released Making Health a Shared Value call for proposals, as well as providing technical assistance. More information is available about our other programmatic activities and funding opportunities on our website. Today, we're really just going to focus on the Making Health a Shared Value call for proposals. So let me turn now to Claire to offer some overarching context about Making Health a Shared Value and the rationale behind this call for proposals. Claire?
Thanks, Erin. Hi, everyone. So the Robert Wood Johnson Foundation developed the Culture of Health Action Framework, which is organized under distinct action areas and identifies priorities for driving measurable, sustainable progress and improving the health and well-being of all people in the United States. This call for proposals focuses specifically on Action Area 1 of the framework, which is called Making Health a Shared Value. This action area highlights the importance of individual, family, and community factors in renewing and sustaining a societal commitment to health, well-being, and equity. And the purpose of this call for proposals is to improve our understanding of the Action Area 1 drivers and outcomes related to health, well-being, and equity, particularly with respect to disadvantaged children and families. We also hope that projects funded under this call will contribute to continued refinement of the Culture of Health Action Framework and will help us to develop the evidence base needed to understand the relationship among different components of the framework, as well as the direction and magnitude of the impacts. In addition, there are a number of different areas of work within the Foundation that are very invested in trying to better understand this action area, and we're really excited about the kind of work that we're going to get in from you all in response to this call for proposals. I also wanted to just say I saw that many of you had sent in questions about wanting more detail about who are we talking about when we say disadvantaged children and families, and it's a slightly unfortunate phrase, but what we really mean are low-income children and families who can face significant socioeconomic barriers to achieving the best health possible. And when we were talking about children and families, I saw lots of questions about the different types of interventions and whether those what we were most interested in. And so I just want to say that by children, we mean people 18 and under. And when we talk about children and families, we really are talking about families whose children are under age 18, not those who have grown into adults and moved beyond that. So we're particularly interested in learning more about Action Area 1 in the context of children and families because of one of our thematic areas within the foundation called Healthy Children, Healthy Weight. And we focus specifically on implementing strategies to achieve the best health possible for children and their families in the United States. So it's a fairly broad context, but as much as possible, we want to fund work that focuses explicitly on children and their families. So I'll stop there and turn over to Mei Lin to describe the drivers aligned with making health a shared value.
Thank you, Claire. There are 3 drivers that form the basis of Action Area 1: mindsets and expectations, sense of community, and civic engagement. Mindsets and expectations are how people think about health, well-being, and equity, and the extent to which they value health and view their own health as interconnected with the health of others. Sense of community is about how connected people feel to their physical or social community. And this could include neighborhoods, other in-person groups like personal or professional interest groups, social networks, or online communities. And civic engagement embodies the wide range of activities that individuals and groups perform to bring changes to society. And this could include voting, volunteering, organizing, holding office, participating in events, and other forms of service or advocacy. These 3 drivers each embody an array of related constructs and measures, and together they point to the importance of shared values in promoting population health. While the drivers are anchors for the research that's relevant for this call for proposals, the specific terminology that we've used to describe each of them should not be viewed as rigid definitions. Instead, you can think of the drivers as points of reference to help conceptualize the elements of a shared value system. And we know that around the country, people are actively working on these issues, although they may not think about their work in the same way that the Foundation has framed them here. Now that we've covered the rationale and framework for the CFP, let's get into the specific details. Nancy, can you talk about the type of research we're hoping to fund?
Sure. We have 2 key aims for funding under this call. The first is to test the effects of specific interventions on the Action Area 1 drivers, and this is to determine the extent to which these drivers can in fact be changed. The second aim is to establish evidence of causal relationships between a change in these drivers and health outcomes. Although it would be wonderful to have projects that can achieve both aims, again, the aims are to establish the extent to which drivers can be changed by intervention and to determine the impact that change has on health outcomes. So ideally, we'd have projects that could do both of those in the same population. But we also anticipate funding research that addresses either of these aims independently. So in sum, we hope to support research that can assess the potential of drivers to move the needle on health, well-being, and equity outcomes for disadvantaged children and families. So if we can go on, let me also explain the approaches and outcomes. We welcome a variety of research methodologies and approaches, and these can include independent evaluations of program or policy implementation, randomized trials, quasi or natural experiments, mixed methods, network or systems analysis, and if there are other relevant methodologies as well. We really take the question as the primary issue, and then the method to analyze it and test it should be appropriate to the question. We also welcome applications that leverage existing programs or build on studies that are already funded through other sources. The outcome should be measured that reflect changes in the drivers and/or health, well-being, and equity, depending on the research focus in question. Health, well-being, and equity outcomes can include a variety of physical, mental, social, and emotional health and well-being indicators, in addition to behaviors or other factors that are well-established determinants of health. So actually, if you look at this call for proposals, you'll find examples of the types of measures that may be appropriate for each driver. And for projects that primarily focus on changes in the drivers, we encourage the collection of health, well-being, and equity indicators as secondary outcomes. Proposed outcomes that are not well-established indicators of health should be justified by explaining the theoretical or empirical basis for their connection between that outcome and health. So let me go on to the selection criteria. The research projects will be evaluated on 6 criteria. The first is the relevant to Action 1 drivers and their relationship to health, well-being, and equity for disadvantaged children and families. I know this is getting repetitive, but we really want to stress these are the linkages we're looking for. The second criterion is that there's an appropriate level of rigor of the research designs. The studies need to include a clear, data-driven research question and should be designed in such a way that either a positive or a null finding will provide useful information. A third criterion is actionability, and this is whether the findings can be translated to practice through programs, initiatives, or policies that influence individual or institutional decision-making and behavior. The fourth criterion is assessment of appropriate outcome measures. The fifth is the contribution to the evidence base, whether the research addresses key knowledge gaps about Action Area 1 drivers, and this can be done by measuring the effects of interventions on drivers and or by establishing causal links between the drivers and change in the drivers and health, well-being, and equity. And then the final criterion on which they'll be evaluated is feasibility. Has the team got the qualifications to be able to carry out the proposed research? Is the budget appropriate? And is the timeline appropriate and doable? So having gone very quickly through a complicated set of criteria, Erin, do you want to talk more about the practical and logistical aspects of applying?
Sure. Thanks, Nancy. So preference will be given to applicant organizations that are either institutes of higher education, public entities, or nonprofit organizations that are tax exempt under Section 501c3 of the IRS Code, but other nonprofit and for-profit organizations are eligible to apply. Applicants must be based within the U.S. or its territories, and the principal investigator is not required to hold an advanced degree. We don't have a traditional definition of a principal investigator, but the applicant team must demonstrate that the ability to conduct that they have the ability to conduct the proposed research. And we do want to stress that applicants from all sectors and disciplines are welcome. So we will award up to $2.5 million through this call for proposals, with the majority of funding dedicated to research that is either specific to or will benefit disadvantaged children and families. The total number of grants to be awarded will be determined based on the number, size, and scope of the studies proposed, although we do expect to award multiple projects, make multiple awards, and we expect that these awards will vary and range in size and duration. There is not an explicit budget per grant, and applicants should ask for the amount that they think is necessary to conduct their study. Again, keeping in mind that we anticipate awarding multiple grants. The grant periods themselves are flexible with a total duration of up to 48 months, but we do have a preference for projects that will produce findings in the near term. This is a two-stage or two-phase application process. The first step is a two-page letter of intent. Letters of intent and accompanying applicant information will be submitted through the Robert Wood Johnson Foundation application and review system, which can be accessed via our website or directly at my.rwjs.org. Through this system, you can download the narrative template, which contains detailed instructions about the specific information we want to see included in the letter of intent. along with guidance about how much of the proposal should be dedicated to each section. I cannot stress enough that you should review this template closely and follow it in your application process. You may create an application and download this template and at a later date decide not to submit, and there's no penalization for that. So I encourage you to go ahead and create an application and download the template early so that you can have a sense of what it is we're looking for. If you are invited to the full proposal stage, applicants will then submit a 10-page full proposal, which includes more detailed information and additional materials. We anticipate that not all applicants will be able to be invited to the full proposal stage, and those who are not invited on to submit a full proposal may be invited to participate in one of our technical assistance services. So again, I would direct you to our website to learn more about those services. Letters of intent are due on June 1st by 12 p.m. Pacific or 3 p.m. Eastern Time. We will not accept late applications. Those who are invited to submit a full proposal will be notified in mid-July, and full proposals will then be due on August 31st. It is recommended that you plan to submit your letter of intent and your full proposal a little in advance of that 3 p.m. Eastern Time deadline, because again, we are not able to accept late applications, and so even if you experience technical difficulties, we may not be able to make exceptions, and so we encourage people not to wait until the last minute to submit your application in case there are any glitches in the process. Successful applicants will be notified of funding on October 26th, and grants are expected to start December 15th. And this is the grant start date for all applications in this, through this proposal. So I want to stop there. I'm sure there are many questions. In fact, I can see the many questions that have been submitted. So I know that the most benefit is probably comes from us answering your questions, and so I want to move right now to those. There were questions submitted in advance, which I have as well, and we'll be able to field during this time, along with the questions that you are submitting through the chat feature. So let's get right into the questions. I'm going to start with a really excellent question about how this call for proposals differs from the other rolling E4A call that is open currently and simultaneously with this call. So, and how might one think about whether a project should be submitted to the open call or to this specific Making Health a Shared Value, to the rolling call versus the specific Making Health a Shared Value call. So Nancy, do you want to speak to that a little bit?
Sure. The open call is really unconstrained in terms of area. So people can be applying to address issues in any one or more of the action areas. In this call, we're really limiting it to those that are focusing primarily on Action Area 1. And the other constraint, although it's not as much a constraint, is that we give a preference in these applications to those focused on children and families, whereas in the open call, it can be on any age group.
Great, thank you. Claire, do you want to add anything to the distinction between the two calls?
No, I would just add, Erin, that any of the proposals that come into this specific call could also go into the open call. The reason that we're doing this specifically on Action Area 1 is because we've been open since the summer of 2015. We've had very, very, very few proposals in Action Area 1, and the RWJF is keenly interested in learning more about this, making health a shared value. So we're really trying to focus everyone's attention in on this.
Great, thank you. So we've gotten a couple questions, one currently through this live submission and some in advance about community-based participatory research, community-led research, and how we think about funding that sort of research versus research that might be led by an academic institution. So Nancy, if you want to speak for just a second about how we think about CBPR style research.
Well, we certainly value it. The question really will be whether the process is far enough along with the community and the researchers that the research question can be articulated and the design is set. If you're very early in the process, if you're just starting out to explore with a community a problem area but haven't defined what the shared issues are and what the appropriate design would be, it will be hard to articulate that in a research application.
Great, thank you. So there's a couple of questions that are asking about who are the appropriate principal investigators or who are the appropriate lead organizations. So let me just start by saying, sort of reiterating what I said previously, we do not require that our principal investigators hold an advanced degree or be the researcher, so to speak. We do require that the entire team of applicants demonstrate the capacity needed to carry out the design and the expertise needed to carry out the study. Again, I will say you're not required to submit as a team. You could be an individual, although the strong proposals that are submitted through E4A often do reflect input of a variety of different disciplines or sectors along the way. And in terms of who the lead organization is, I really just encourage people to think about the logistics of administering the grant. And so consider which organizations are best suited to receive the funding and to administer it to whichever other parties may need to receive funding in order to participate and to manage the logistics of the study. That's usually the approach that we suggest, and we truly do not have a preference for either the lead organization or the principal investigator. Nancy or Claire, either of you would like to add to that comment at all?
No, that's right.
Right, and I would just say that we really welcome new applicants, folks who have not been participants in any RWJF programs in the past.
Great, thank you. And someone had specifically asked about doctoral students or community members, so just to underscore that, yes, those are eligible applicants. So there are a few questions about what sort of examples of the types of studies that we might fund. Is there a priority for intervention-based studies, or is there any other priorities besides those we've already indicated? So let me just start by saying to this point that Claire made earlier in terms of that any project that could be submitted through this call would also be eligible to be submitted through our open call. If you want just a general sense of the type of research that Evidence for Action has funded through our rolling call for proposals, there are descriptions of all of our grantees on our website. And we provide summaries of the projects and also more detailed information about the types of outcomes and the research design. But in terms of examples for what we're looking for specifically through this call, I would maybe defer to Nancy to see if there are any examples you'd like to share. Although I know that we've really hold tightly to our guidance to be an investigator-initiated program.
I know I can just say generally, as we think about it, if there is some activity that's going on, for example, in a community that should change the sense of community, or should change mindset and expectations or civic engagement, a good study would be one that would swoop in, hopefully, and have baseline data, be able to show that the community efforts worked as they should, and then looked at the impact on mindsets and expectations and sense of community or civic engagement, and then ideally could link to something like electronic health records in that community and see if there were changes in some health-related outcomes.
Great, thank you. Claire, any examples you would like to share?
No, I would just point folks to the CFP because we did give some broad examples, and I would say that we are very intervention or initiative focused. So work that really predates an initiative is not as interesting to us. We really want to see whether we can create a shared value when there was not a shared value for health before.
Great, thank you. So there have been a couple questions if we can provide a little bit more detail or maybe some more example about the drivers. So Maylin, would you mind starting us out, since that has been a lot of your focus in preparing for this call, to think about the drivers and to think about the context within which we consider the work in those spaces, and then we can also turn to Claire and Nancy to add detail.
Sure. So the three drivers, as everybody has mentioned earlier, have been defined by the Foundation, and they are mindsets and expectations, sense of community, and civic engagement. And the motivation, part of the motivation behind this call is because there is actually quite a bit of evidence out there that these constructs are associated with either individual or population health, but there's not a lot of evidence showing the causal link between changes in these drivers and health outcomes, or even interventions that can actually change these drivers at the individual or population level. So, so that's sort of the motivation behind it. And I will also emphasize that the way that the Foundation has defined these constructs shouldn't be the only way that people think about them, because there could, within, for example, civic engagement, that could actually entail a lot of different types of activities involving political or community participation. And so researchers really shouldn't be restricted to the way that they've been defined here, but understand that these are the three areas that are thought to drive this action area forward.
Great, thank you. Claire, do you want to add anything?
No, I think that was really well stated. I agree.
Great. Nancy, any additions?
No, well done.
Wonderful. Okay, so there are a couple of questions about implementation and the extent to which we might fund implementation versus research or in partnership with research. So let me start by saying that the overwhelming majority of the funding that we issue needs to go towards research and activities associated with research. And sometimes the interplay between the implementation and the research is so closely interwoven that you really can't separate them, and those are the times when it makes most sense for funding to be able to be allocated towards intervention. We don't have an explicit percentage or dollar amount that we have deemed appropriate for for allocation between intervention or research. It really is a case-by-case basis. But I will say that, again, sort of the overwhelming majority of funding awarded needs to go towards research activities. And similarly, there's a question about whether intervention development could be part of the funding or whether the intervention already needs to be in place to test the change in outcomes. And so I would say that in our experience to date, intervention development is really too early for evidence for action funding, and I would say that is probably going to be the case with this call as well, where both in terms of the amount of time for which we are awarding funding and the ability to see a change, that would predispose those projects that are evaluating interventions that already have been established and are underway. And also in terms of the stage of research that is best suited for evidence for action, in which we're able to really test the impact of the implementation. Any additions, Nancy or Claire? All right.
No.
Nope.
Great. Okay, so moving on, there is a question about whether funding is available for projects in rural communities, and so I would say yes, absolutely. We really would like to see projects submitted from rural communities. I think that a primary issue that we've seen in the past is the sample size. So there's also that is able to be drawn from rural communities, but we've engaged in a number of conversations with people working in rural settings about sample size and recruitment, et cetera. And so I think that there's definitely room to fund studies in rural research in rural communities through this call and through our general rolling call as well. Related to the sample size question just generally, that really is an intervention or a dependent question or a study research dependent question. So it's case by case. And then appropriate sample size is, of course, dependent upon the likely effect size for each intervention. So we don't have a pre-specified sample size, but we do closely pay attention to the sample size and whether or not it is sufficient to detect an impact of the intervention.
Erin, I might add something here because I think people may not have understood, or at least I think it's often not clear what we mean about null findings as well as positive findings being informative. We want to be sure that there's enough of a sample size to find an impact that will be meaningful. And we're looking for studies that are designed well enough that if it's not found, you might need to conclude that the intervention actually doesn't work. If you have an insufficient sample size, if it's equally likely or more likely that it might work, but you couldn't find it because you didn't have a large enough sample, then it leaves you not knowing what to do. So that's why we stress both sample size and the rigor of being able to have both a positive and a negative finding be informative.
Great, thank you. I think that's an important point to raise here, especially because that is such a critical decision consideration for us, this issue of null findings. Claire, there's a question about whether work is required to be conducted in the United States or if it could be carried out globally with implications for the U.S. Do you have some thoughts about that?
Absolutely. Yes. That's the short answer. The work can be carried out in a global setting, but it has to have a very, very explicit relationship to what happens in the United States, so the learnings can translate directly to our systems here. So I would just think very carefully about that before sending in an application.
Great, thank you. And let me stay with you for just a minute. I know you went over when you were talking about the focus on disadvantaged children and families, sort of what constitutes a child and a family unit, et cetera. But we've still gotten some additional questions coming in about sort of if there's any more specificity around the types of families or if the definition of children might include unborn children. And so if you don't mind maybe taking a few more minutes to talk about the target population, disadvantaged children and families, and any additional either prioritization or any additional breadth of that definition.
Sure. Okay. These are great questions. Thanks for sending them in. And I would say we are primarily focused on children, not on pregnant moms or the babies before they're born. We're really focused on birth, really up to 18. I will say that in our Healthy Children, Healthy Weight work, we are primarily focusing on younger children. But for this call, it really is open up to 18. Because the field is wide open. There just is not a lot of work in this area. So that's, I think, an advantage to you all as you apply. We're really, when we say disadvantaged, again, it's sort of an uncomfortable term, but what we really mean are families who have significant income challenges that introduce just real challenges and barriers to accessing services and accessing opportunities to achieve a really healthy life. And as part of that, I think we can, emphasize that RWJF has a strong equity framework. So we really want all children to have the opportunity to live a healthy life, and that means that our programming primarily focuses on families who face these just really consistent challenges. So those are there is definitely not something that we're keeping from you all. I mean, our decision making is going to be focused on all of those facets of your proposal that Nancy and Erin described. So the combination of the strength of the research design and the study population. But the study population that we're really, really hoping to get are children and families.
Great, thank you. And if we can build just a little bit more off of this point that you just made about focusing on equity. The foundation is focused on equity. The call itself is really focused especially on equity. So there is a question about how the program and the foundation more broadly think about equity and beyond economic equity, issues of racial, gender, structural advantage or bias and discrimination. And so if we can talk a little bit more about that, and then also if there's a measure for equity that we already consider well documented. So maybe if Claire, if you don't mind starting, and then Nancy, I'll maybe turn to you, especially to think about the measures of equity.
Sure. So I would say that we think about equity in all of the ways that Erin just laid out. So it is not just one facet. So we're not only talking about racial and ethnic equity. We really are. It really runs the gamut. So we have a very complete, holistic view of equity. And I would just say, I think this is an area that RWJF is continuing to invest in, but I would say that typically when we think about measurement and equity, right now we really are at the place where, looking at differential impacts among different populations, really separating out populations by race and ethnicity and income and gender and all of those different aspects of population characteristics is really one of the best ways that we have right now to demonstrate equity. So if all populations are experiencing equal opportunities and equal health, then we would say we probably have equitable health and care for folks in this country. So Nancy, you probably have a better way of describing that or a lot to add.
Actually, I thought that was a great description, and especially at the end. I think the equity really does encompass equal access and the possibility of equal outcomes. And, so we would be, I think, particularly interested in studies that would look at the question whether the intervention not only is beneficial, but whether it closes the gap between more and less advantaged groups.
Great, thank you. So I'm trying to balance back and forth between some of these sorts of questions, which are at a sort of higher, more conceptual level, and then some of the very specific logistical questions that we're getting. So I'm going to touch on a couple of quick logistical questions. One is about pilot data and if pilot data is required. So I would say no. However, it can't hurt. If you have pilot data, you should share it in your application, or at least state that you have it at the LOI stage. But it's not required, certainly. And then another logistical question is, do you have a limit on how many letter of intent submissions will be invited to submit a full proposal? Will all relevant submissions be invited to submit a full proposal? And then similarly, is there a limit on the number of applications any organization can submit? So I would say there's not a limit on the number of applications that an organization can submit, either through the Making Health a Shared Value or through our rolling call for proposals. I would say that, yes, there will be a limit on the number of letters of intent that are invited to submit a full proposal. So through our rolling call, We have a relatively low invitation to full proposal rate of invitation, but I don't think that that's entirely indicative of how this call will go, mainly because we've just received so many applications through that call. But we have a very high rate of funding at the full proposal stage. It's about 40% of applications that are invited to submit a full proposal through our rolling call are funded, and I think we do intend to have a similarly high rate of funding through this call for proposals. So anywhere from maybe 30 to 40% of applications, and so we really will. One of the benefits of having a deadline-driven application process is that we can compare letters of intent to each other, and we can compare projects to each other, and we really will try to invite those that are most likely to be competitive and to get funded, given the constraints under which we're operating in terms of debt timelines, budgets, etc. Having said that, Claire, let me see if you have anything to add from your experience doing this with the foundation.
No, nothing to add. Thanks, Erin.
Okay, great. So let me turn them back to a little bit more of a higher level, but equally as important, interesting question. Which is, do we have any thoughts about why so few people are tackling this priority? So why have we not seen many applications coming through our rolling call for proposals looking at this topic? So Nancy, why don't I start with your musings, and then Claire, we'll see what else you have to add.
Well, unfortunately, my musings are just that. They're musings. We don't know exactly. It seems likely that these drivers are not that easily amenable to modification. We're used to doing kind of individual, working with people to change their behaviors or changing a clinical setting. To actually change at a community level, and then to see how you compare that with what if you hadn't changed it that way, or is it really effective compared to other things that you could have done? Is a bit daunting. So I think that may be why we haven't seen as many. But we were hoping that there are some good examples out there, and this call will pull them in.
Claire, thoughts from your broader experience at the foundation?
Yeah, one of my guesses is that our traditional audience for RWJF partners and grantees is primarily focused on people who live in the public health world or in medicine or in nursing. And I don't think that most of these areas within Action Area 1 are sort of traditional areas of inquiry for the folks that we have most frequent contact with. So I think partly it's a little bit of an audience question. But I don't think there's any, I don't think those are, I wouldn't worry too much about those. I mean, I think this is a really fantastic and exciting opportunity, and RWJF really can't wait to learn more from you all. So I hope you all will send in some proposals.
Thank you. And there's one thing I might also add to what you both said, which is in our general rolling call for proposals, we have a very strong requirement around health outcome measures. And one of the things we've seen with these proposals that have been submitted, the very few that have been submitted, is the difficulty in being able to draw causation from the intervention to changes in the drivers to the health outcome measures. So that's why you see in this call that we do have the two aims. And as Nancy mentioned, certainly our preference is to have both of those aims tested in the same project. But we do recognize that that may not be possible. And so we will accept applications in which the primary outcome is a change in one of those drivers. And that health outcomes are looked at on a secondary basis. And that's something that's different between the two calls, and we're hoping will encourage more people to submit applications that can be competitive through this call. So let's turn now to a couple of questions that are about scale. And so one is, these are separate but related questions. So one is about how big a community of focus would be appropriate to satisfy the scale desired. So sort of are you looking, and similarly, related is sort of about whether individual interventions are appropriate versus community level interventions. So is a project that's built to change the mindsets of individual members of a community appropriate, or does it need to be a community level intervention? So Nancy, do you want to start by speaking both about what constitutes a community and then also the scale at which we're looking to see change?
Well, I off the top of my head, I actually don't have a good definition of community. I mean, the most obvious is geographic community, but it also can be, we all belong to multiple communities, and I think there can be interventions at a community level that are not necessarily a city or a state. In terms of the individual or social, some of these will obviously work through individuals, and it's hard to change the mindset of a community. I mean, we can change the norms, which in some ways reflects the mindset. And so we're open to projects that are focused on individuals. The issue there is it something that can be scaled up? So it's not specific to a small group of individuals that require very intensive interventions. So I'd say the more it's scalable and applicable to other communities, the more likely it would be to be of interest to us.
Great. Maylin, I know as you were doing the research to inform this call, you talked to some people about what a community meant. Do you want to share a little bit more? I know you mentioned it briefly when you went over the details of each of the drivers, but if you could talk just a little bit more about sort of what community means.
Sure. So as Nancy said, they could be a physical community like a neighborhood, but the driver here is really somebody's sense of community. So there's sort of their sense of belonging to some network or source of support. So again, that doesn't have to be necessarily physical or geographic. It can also be online. It can be through long-distance relationships and things like that. So I think that is that's one potential way to think about community, and particularly not just the definition of the community itself, but somebody's connection and relationship to their community.
Great, thank you. So just to reiterate for people, you should define in your application. You should define the community that you are that you're referencing, and we have the community could be broadly defined and exists in different contexts. So turning back to a couple of logistical questions. One is about are mixed methods allowed? Yes. The short answer is yes. Mixed methods are appropriate, both quantitative and qualitative. We have a similar level of rigor requirements for qualitative research, and so we just ask that you take that into consideration when you're thinking about the qualitative components of a study. And then similarly, another question was about if drawing association between the drivers and factors of intervention is adequate. So what if you can draw correlation but not causation? Nancy, do you want to touch on that briefly?
Our preference is for causation, because the problem with correlation is unless you can rule out all the confounding factors that could lead to alternative explanations, again, you're left not knowing quite how much weight to put on the finding. So there may be things where correlation is so powerful that it would be informative. But in general, we're really seeking evidence of causal impact.
Thank you. And tied to the person who asked that question, tied to your question was whether or not quasi-experimental was appropriate. And so I would say certainly quasi-experimental designs are appropriate. We're not just funding randomized control trials, and I think it's also important to note that RCTs are really the gold standard in the health space, but we know that in other disciplines there are other gold standards for drawing causation, and that all designs really have their benefits and their limitations. And so I just want to be clear that there are a variety of different designs and approaches are appropriate. We do not have a specific design that we have prioritized over another. And I know there was another question about sort of the approaches, and we went over a few of them. There are also examples included in the call for proposals itself, so I again encourage you to read the call closely, and also to take a look at the grantees section of our website. Each of the grants, again, has a summary as well as a description of the methods, and you'll see quite a broad range of methods that are being applied towards the research that we've funded through our rolling call, and I think that's still applicable through this through this Making Health a Shared Value call as well. There is a question about how we define intervention. And so I'll start and then see if others would like to add. But I would say we define it relatively broadly, meaning that it could be a program, it could be a policy, it could be some sort of partnership. I do think that evidence for action is well suited to evaluate programmatic interventions compared to some of our sister funding programs through the Robert Wood Johnson Foundation. But again, we don't have a specific definition of intervention. It's relatively broad. I noticed that someone gave an example about working with community members to identify policy priorities and whether that might be an intervention. I think that's a tough question to answer. On its face, I would probably say no, but it's possible if there's some specific approach towards community engagement that's being employed, that could be considered an intervention. So let me see, Nancy, if you want to add to how we think about intervention, and certainly Claire, if you have additions as well.
I guess I think of intervention as a purposeful action, that it's something that you are doing because you believe it will lead to the outcome that you want. So, for example, if the community consultation with communities about setting priorities is undertaken because the belief is that very action and that experience will lead to good outcomes, and there's a good control or comparison group so you can know that it's that activity, then that is, I'd consider that an intervention.
Great, thanks. Claire, any additions?
No, I think that covers it, except I just, to add on to what Nancy was saying, I agree, and I would also say a number of our studies are almost looking at unintended consequences, and I think that that's also an opportunity. So it's a purposeful intervention, but we may be looking at the health effects or the impact for a different proposed hypothesis than maybe the original, if it was a policy change or an intervention may have been undertaken for a different reason. So it's a purposeful change, but not always with exactly the same intent as we may expect.
Thank you. I think that's a great addition. That is something we are often very interested in, so good for people to know. And just to add to this, again, the breadth of possible things that could be considered an intervention, somebody asked specifically about whether technology-guided or technology-based improvements constitute an intervention, and I would say sure, that could definitely be considered. We've seen applications before for technology improvements and technology solutions, and I would say those do constitute interventions, along with the variety of policies, payment plans, programmatic activities, et cetera. And so I would say in general, across the board to these questions, that we're getting a lot of very specific questions about types of programs or policies. I just would encourage you to convince us that it's an intervention. We have an open mind. We are open to being convinced of the practicality or the importance or the definition of your work, and so feel free to do so. The one thing I will say in terms of the convincing that's needed is that as you're developing your proposal, we don't need to, most of the time, we do not need to be convinced that this is an important issue. We rarely see applications to study issues that are important. We rarely see, applications to study issues that are not important, and we rarely need to be convinced of the importance. So I would just encourage people not to spend too much of your application trying to convince us that your work is important. Most of the time it is, and we don't need a lot of convincing of that. And similarly, I would say for those applications that are turned down, it's certainly not an indication of whether or not the work that you're doing is important or in our belief that it's important or not. It's often related to the rigor of the design or the relevance to the culture of health action framework, et cetera. So we're really getting close to the time. I'm going to try to squeeze in one more question, and then I know we weren't able to get to all of them. I apologize, but I encourage you to turn to our website for more information. And again, to the call for proposals itself, where there is quite a bit of more detail about this, about all of the questions that have been being submitted. The last question I'll raise for us is just about sort of the distinction between research or evaluation. And for someone who's come from the practice side, I would say I guess I can understand this distinction between programmatic evaluation versus more rigorous research. But what we're looking for is rigorously designed research that evaluates the impact of an intervention. And so that often means there needs to be some sort of comparison or control group. And as Nancy mentioned previously, we really are looking for causation when possible, although there may be instances in which correlation could be appropriate. We're looking for people to test the impact of intervention on whether or not the drivers can be changed and whether or not those changes yield impacts for health outcomes. Let me turn, Nancy, to you for the last word if you'd like to add it.
The last word for me is I really appreciate the interest, and we really are looking forward to the applications and seeing the good work that's going on.
Absolutely. So if we haven't gotten to your questions, I mentioned the most important places to look, but you can also be in touch with us. There are a variety of ways to reach out and contact us, and to closely review the call for proposals as well. Thank you, as Nancy mentioned, for joining us today. We appreciate the interest, and we look forward to receiving your applications. This concludes our web presentation.